Many of you know the VA, Veterans Health Administration, but just in quick review, VA serves over 6 million enrolled veterans for health care. And we have more than 1,200 points of care throughout the country. We employ more than 250,000 clinicians and clinician support type activities. VA has a very robust electronic health record with wide adoption by all of our clinicians, and it's regarded, our CPRS product is regarded as a tool in clinical care. The computer is not a luxury anymore. It's a part of our everyday clinical practice. There's a little bit of difference between the Department of Veterans Affairs and the other HIEs who presented today, starting with the sustainability model. Our sustainability model is based on federal tax dollars. Our driver for interoperability is our veterans, and many of whom receive some portion of their care from the private sector, from private sector hospitals that are represented by health information exchanges that are on this panel. And so we take the driver from our veterans for better coordination of care with the private sector very seriously, and it really drives our activities with the Nationwide Health Information Network, with participating in the DIRECT project, and all of the activities wherein we can provide information from our systems to private sector clinicians and get information in support of veterans from private sector clinicians. We are actively engaged in the Nationwide Health Information Network exchange activities. By the end of September of this year, we will have be interoperable with 11 sites with 11 different health information exchanges throughout the country. By next year, about this time, we expect to go in a national deployment where, as a member of the Nationwide Health Information Network, any other health information exchange will be able to get veterans' data, provided the veteran has provided the authorization. We are an opt-out shop, meaning that we are going to ask every veteran if they want to share information with the Nationwide Health Information Network, and we will honor their consent directive. If they don't want to share information with the NHIN, we at this moment do not have a break the glass scenario. We will not share information with the Nationwide Health Information Network partners, but our systems are being built right now to support the opt-in characteristics. I'll stop there, Kate.
Thank you, Tim. Next, I'd like to call on Mark Jones.
Kate, thank you very much, and appreciate the ability for all of us to get together and talk about our commonalities here, because certainly we have a tremendous variety of projects, and yet I think we all share some issues about sustainability and governance. SmartNet is really the outcropping of a transforming healthcare through HIT grant from AHRQ in 2005 and 6. And to make a very long story short, it evolved into an HIE utility company whose functions were to build multiple self-governed, sustainable networks that could also share data within Oklahoma and also outside of Oklahoma. To date, we have created 8 different self-sustaining networks that are governed within their own structures. 4 are regional networks. There's a hospital network in Oklahoma City with 13 very large hospitals. Norman Physician Hospital Organization is one of the leading technology projects in the country. It is a part of a challenge grant about transitions of care and involves a local network, an API for prevention and SmartNet interoperability. There's a rural safety net network. There's a urban safety net network. There is SmartNet Direct, which is an open network for anybody in Oklahoma who doesn't have a network yet. The Oklahoma State Medical Association for all physicians in the state. The Oklahoma Association of Optometric Physicians, which is all the state's optometrists. And our latest network is an intertribal network of the state's 4 largest tribes. all of these networks participate together in a common effort as well as their own effort. So as an aggregate, they now have 2.3 million patients, which is about two-thirds of the population of Oklahoma, about 15 million diagnoses. Data is coming in from 64 cities and all 77 counties. We also played a very important role for 90 days in bringing up a project in Tulsa, which utilized the planning effort to become a beacon community. So the networks together individually can choose their own members, services, do reports. They're all nonprofit, set prices, training, and use their own technology or borrow ours if they don't want to go through that process. In the middle is the SmartNet governance process, which is members of each network sit on a common management system. That common management system has evolved over 5 years, almost cost $5 million for the resources for it. So the resources they share, so they don't have to reinvent the wheel, are a common network of networks management system. There are 14 interoperable legal agreed documents for various phases of development, 27 security policies, common default technology. We also help with EMPI, training the trainers, and literally 20 other services. The key to it is something that sort of evolved in the process of building our network. We had to report to ARC how we built it, and watching ourselves do it, we developed some tools that all these networks are able to use. So, for instance, the planning process requires a meeting of the governance groups across all the members for a potential new network. They need to resolve 15 issues we've identified. There are 14 legal documents to study, 27 security policies, clinical benefits, individual ROIs, and specific issues to each network. So there's a commonality in the middle where they share a lot of resources. They're also very independent to do what they think that they need to do. We are a participant as one of the nation's direct projects, so we're standing up a direct secure messaging process right now. We're very interested in utilizing this network of networks to build something I think one of our projects said earlier, which is essentially a small-town self-governed network. We think that there's an impact grant out there that would help us to implement multiple efforts where the citizens in each small town could actually help drive its own healthcare system. So we're very interested in that. The issues around sustainability, primarily subscription, but we think because these networks are very close to their users, represented by the users themselves, the value becomes so apparent from being in such a close set of relationships that it makes sense to continue that. We think the trust is really big. For instance, the SmartNet Management Committee meeting is available on statewide television through the Oklahoma State Health Department, and the costs are low, around $30 for a physician. So I think with that, I would just simply end by saying where I think we're going is to ACOs, to medical homes. A lot of folks are using this infrastructure to apply for new grants, PHRs, and certain population analytics. So, Kate, thank you very much for asking us in, and we very much appreciate being able to work with the group here.
Thank you, Mark. Before we go to the rest of our participants on the phone, I do want to just briefly introduce Michael Solomon with Point of Care Partners, who is one of the authors of the report, who helped NEHC kind of pull together the profiles and the report that we'll be releasing very shortly. And I want to also, pause here and introduce Claudia Williams and Jason Kunzman, who have joined us from ONC, and offer them a quick chance to make an observation or two before we have the overview from the remaining HIE leaders. Jason, you want to?
Thank you, Kate. I have the coolest job in the whole world because I get to work with 17 of the hippest communities across the country, many of which are represented on the panel today, and working diligently to establish robust health information exchange capacity. It's not easy work. We've got folks that are ranging in sort of the status of their journey from folks in Tulsa that Mark mentioned, where they're looking to stand up, initially stand up a health information exchange, and folks like Tom out there in Washington who have been at this for a long time. So the set of challenges is, if you've seen one Beacon community or if you've seen one health information exchange, I think you've seen one health information exchange. We know that healthcare is local. A lot of the challenges are unique to each of the communities that we're working with. I think it's great. I love the level of conversation around sort of the ancillary services and products that folks are looking to sort of hang off of their health information exchanges, from business analytics, community-wide clinical decision support tools, and the like. So I'm very encouraged by the utility of the infrastructure that is being laid out across the country. I think we're headed in the right direction. It's going to take a while, though, for us to get to where we eventually want to be. But again, it's exciting work, and for whatever it's worth, I commend all of you on the panel and those across the country that are looking to utilize this sort of connectivity to improve the quality and reduce the cost of our overall system. Claudia?
Thanks. I think a couple of us actually came over here appropriately from the summit that's happening across town on ACOs. I know John just spoke there, which I think is an appropriate, I don't think a day goes by that there's not some kind of a summit or effort to try to parse and figure out these linkages between the healthcare transformation agenda we're all looking at and the IT infrastructure that we are also in the middle of trying to implement. I'd also like to introduce my colleague Chris Muir, who's joining us here. I wanted to just reflect, sort of thank you for the lessons you've provided today and tell you a little bit about how we're trying to take some of those lessons forward in the HIE program. And we can always use your feedback about whether we're doing it well or not and how we could do it better. So one theme came through really, really strongly to me, and I think it was even mentioned by somebody on the phone specifically, which is being close to your users. Now, as a state, it's often hard to figure out what that means. But one piece of advice and guidance and work we've been doing with our grantees is to say, first of all, have users, like have a conception of what you're trying to accomplish and for whom and the value you're bringing, and be able to track whether people are actually using that service and sort of buying the value. So that it's we've all seen models where you launch some cool IT thing. I think somebody over here even mentioned it. You're really excited about it, and at the end of the day, no one's using it for nothing. So one of the pieces of guidance we've really tried to give to folks is provide value in the near term and make sure they're actual users finding value to do the kinds of care jobs we're asking them to do for meaningful use. So a real focus on meaningful use, a real focus not on some 10-year goal, but doing something this year that can provide value to folks and seeing if people are actually adopting and using that as a metric for success. I think another theme I heard, and I think John particularly brought this out, is, actually several of you did, even within a community that's adopted sort of a particular approach to HIE or HIT, people are in different places. And we are not going to be able to offer a model that gives, your prefix for everything you need to do, that everyone's just going to simply purchase and say, done with that. So we may need to work with folks who are just barely able to, launch their EHR systems and need a really simple, scalable way to send a result to somebody or send a care summary. And direct may be the best way to do that. We're in the middle of that grand experiment.